For those of you joining online, a very big welcome. My name is Maya Brown. I'm Health Equity Lead here at Biodesign. And for those of you for whom this is the first talk, this is part of our ongoing series of health equity innovation talks, where every month we bring in a different academic, a different entrepreneur, a different practitioner, talk about themes related to health equity and innovation. We hope that it catalyzes conversation, new ideas, and critical thinking around these themes that are so dear to us. So a big thank you for all of you joining in person and online. For the in-person group, can I ask you to put your phones to silent? For those of you who are not familiar with our building, the restrooms are through this door, straight ahead. And please do feel free to grab snacks throughout the presentation. And then in terms of our partners, before I hand it over, I just want to say a big thank you to the Center for Innovation in Global Health. The Bay Area Global Health Alliance is well represented here today, and the Stanford Global Health Graduate Network, who form part of the team and help put these events together every month. So on to today's talk, I'm very excited to be able to introduce Neha. She's a passionate advocate for global health equity and approaches her work with strong vision for sustainability, respectful collaborations, innovation, and analytical rigor. She has 15 years experience in global health and life sciences and is currently the Director of Strategy, Office of the President at PATH, and formerly the Global Diagnostics Program Co-Director at PATH, where she led a team responsible for improving and ensuring equitable access to essential diagnostic products in resource-limited settings. The bio is very long, but I'm not going to read all of it. I'm going to say, though, we're hugely grateful to have you here today, Neha. She's going to be speaking to us about outcomes-based financing for antimicrobial resistance, which as Biodesign, we are at the point we're really interested in learning a lot about new and innovative financing instruments to help us think about how do we actually fund some of the work we're doing in health equity. And through applying outcomes-based financing to this case study, we really hope that we can learn what are the innovative approaches you and your team are taking and what lessons can we draw from that. So thank you very, very much for being willing to give the talk. And thank you to Sarah Anderson, the Director of the Bay Area Global Alliance, who's also here today. And I will hand over to you.
Thank you. There are plenty of seats in the front. I promise I won't call on you. Here to sit on the front. But thank you all for being here, and I'm so excited. You won't believe this, but this is the first forum that is actually officially seeing some of the data that's coming out of our year-long research. As we speak, our Tanzania colleagues have just wrapped up their own Ministry of Health workshop sharing the same data, and our Senegal workshop is actually happening tomorrow. So you are very much like in the process of hearing this as we're sort of digesting the information. And so maybe a couple of caveats is that the data that you'll be seeing is sort of unofficially embargoed, meaning that we're still working on it and there's still maybe some open questions that I can't fully answer today. And in terms of the financing pieces, this is sort of just the beginning. So we'll get into the sort of the initiative outline, but really here we're sort of looking at what is happening on the ground in these specific regions as it relates to antimicrobial resistance. And so I hope it's interesting, and I understand that there's time at the end for Q&A. I normally use informal, but since I know there's folks online, maybe we can just, unless you have any burning clarifying questions as I go, we can sort of save the questions for the end. So let's get started. I just... Oh. Great. So today we'll be talking about incentivizing AMR stewardship, antimicrobial resistant stewardship with outcomes-based financing. And I'll talk a little bit about what outcomes-based financing is and how it's generally an underutilized tool in the global health space. But before we begin, Sarah and I thought it'd be nice to provide a quick overview of each of our respective organizations. So today I have the pleasure of representing both PATH and the Bay Area Global Health Alliance as I serve on their board. PATH is a global health nonprofit. We've been around for 47 years. For those of you who know, that predates the Gates Foundation. A lot of people think that we exist because of the Gates Foundation, but we actually precede them by many years. And really, we started with this mission of improving global health equity around the world through innovation and partnerships and health system resiliency. Yes, we are headquartered in Seattle, Washington, but we have offices all over the world and we operate in over 70 countries. We do a lot of work across the continuum of care, and most likely if there is sort of a global health issue, PATH has one or more program teams working on it. And not only do we have health area expertise, but we sort of have multi-sectoral, cross-functional expertise. And so looking at digital health and its juxtaposition on maternal health versus vaccinations and product development. So there's a lot of what I call matrixing across PATH, which gives us sort of the breadth and depth that allows us to interact with our ministries of health in country and really earn the trusted partnership with them. So that is PATH in a nutshell, and maybe I'll quickly turn it over to Sarah.
Yeah, thank you, Neha. Thank you, and it's wonderful to be co-hosting this series, and it's nice to see many of you again. For those of you who don't know us, the Alliance really was formed so that we could bring together diverse sectors together to and connect them with traditional global health stakeholders, as well as to make sure that we're engaging the tech sector and innovation with the traditional global health stakeholders. And we serve as a neutral convener, connector, communicator, and broker of partnerships. And we're more than 90, I think we're 97 members today, really working to how can we advance global health equity and innovation. And we're very diverse, but I wanted to put out there that we're 41% tech. Obviously, you guys are a wonderful partner here at Stanford, and we're also about 36% Bay Area based now. So we've really shifted over the last 5 years, and we're just at our 5th year now. And we also have about 14% that are LMIC based organizations, and we want to keep growing that there. So I have one slide, and I just go like this. Okay. So I just wanted to kind of tell you a little bit. We say we're a neutral convener and connector and broker collaborations. I wanted to kind of walk through a little bit of Neha bringing us this brilliant idea back in 2022 that said, maybe we should do like a social impact bond or something to curb AMR. And we got together, 3 of us from the board, very diverse backgrounds, with Neha, and kind of churned over that idea and what does that mean, and decided we'll reach out to our network and iterating. And then we've also do a lot of convening, and so we brought people together with Neha and PATH at the UNGA, a private roundtable to like, how does this sound to you all and what to do? We've iterated further. She's going to tell you about the exciting research that's going on. And then the Alliance also serves as an amplifier. So once the report comes out, we'll be disseminating that with funder groups, with corporates, with other people to kind of say, how does this sound and how might we get it implemented? So I just wanted to share a little bit of that, just to tell you a little bit more of what neutral convener, collaborator, what that means in concrete terms. Neha, back to you.
Sarah. Yes, and I can't emphasize this piece enough about the networking. It sounds like such a nebulous term, but I would say the best ideas really come out of conversations, right? It's not the eureka moment in the shower. And I think the Bay Area Global Health Alliance has just been such a great catalyst of bringing people together and really allowing ideas to flourish. So I love how you captured that. So maybe switching gears now into AMR specifically. Many of you likely already know this, but antimicrobial resistance has really been dubbed the silent pandemic. It has taken roughly 1.3 million lives every year. The Lancet Commission just ran a report last year saying that unfortunately we are not meeting any of our targets, and resistance patterns are actually increasing. And they're expecting that mortality will go up to 10 million per year by the year 2050 unless we curb AMR. So that is sort of the backdrop to the problem statement that, you know, when Sarah talked about why we need more novel solutions to combat AMR, that was sort of the foundational step. Right now, current investments are really focused on two broad areas. One is around stewardship. So that's all the programming in place to make sure that healthcare providers are acting appropriately in accordance with guidelines that are well established clinically to reduce resistance patterns. And there's funding being available for new research and development. So as we're sort of rendering the existing antibiotics to be resistant in human infections, there's a lot of promise and hope in a new set of antibiotics being available, right? But I would argue, and I think many would agree, that unless we figure out the market dynamics that are governing the way we use antibiotics today, all of those billions of dollars going into new R&D efforts will also be rendered useless because they'll be exposed to the same resistance patterns, the same human behavior, the same market dynamics. And so really, you know, we're facing a lot of issues around sustainability and financing, meaning that a lot of the stewardship efforts are top-down funded, so they're grant-based or contract-based programming. Countries apply for funding from large donors, from G7 governments. So that money, if it goes away, as we've all just noticed, it has, a lot of the foundational infrastructure that's built cannot be maintained. So that's a critical risk. There's also, if you look deep into the WHO guidelines on antibiotic usage, you look at what's called the National Action Plan. So those are the national level guidelines for curbing AMR. Interestingly enough, there's not a lot of reference to market, behavioral, cultural factors that go into why antibiotics are being overused in the first place. So there's sort of that whole access piece that's missing from the conversation. We also know, and you'll see in the next slide, there's misincentives all along the value chain, from wholesalers all the way down to point of care pharmacies. And that again is an area that has not directly been addressed. I talked about the unfavorable market dynamics. The patient-centric piece, I think, is really critical in this conversation. So a lot of times you'll go into global conferences and there's this debate between stewardship and access, and they're almost at odds with one another, right? But really they're two sides of the same coin. We have to have stewardship. We also have to make sure patients are not losing access. The way that it is right now, everybody is sort of protecting their own liability and their own stake in the game. And who ends up suffering? It's the patients. So we really need to create systems that are patient-centric and don't sort of sweep under the rug the cultural access issues, market incentives that govern all of us on a daily basis. That's just human nature. And so we really need to be more patient-centric. And lastly, there is a lot of lack of integration between the public and private sectors, especially in low and middle income countries. And they really operate in their own silos. And really connected back to being patient-centric, patients don't know, and they don't decide, I'm going to wake up today and go to a public clinic or a private clinic. Oftentimes they flow in between the two. And yet our services are very siloed. And so once again, we're sort of not meeting the patient where they are, and we really need to think about integration. I won't go through all of these, but just to say the literature is extensive and has well documented the drivers of overuse. And like I already mentioned, the national action plans somehow are really only addressing the bottom aspects of these drivers. And what's left over are sort of the financial and business motives and the customer demand and pressure. And those really need to be addressed. So that's sort of where this sort of idea came and where the theory of change started to emerge, where if we can augment current stewardship efforts, right? So not replace them, but actually augment them by addressing the market and social pressures at the points at which they're occurring along the patient cascade, then we can have an opportunity to improve referral and testing rates and eventually improve antibiotic dispensing practices. So that's our theory of change. Now, a quick OBF 101. And full disclosure, I am not an OBF expert, right? We're working with partners who are, but in a nutshell, what outcomes-based financing does is it sort of takes the attention off of upfront activities and inputs and puts more visibility on downstream outputs and outcomes, right? So in this example, right now, a lot of the funding that's going towards stewardship efforts is actually 100% on the left-hand side, meaning your funding inputs, activities, work plans, a lot of those are around establishing trainings, building capacity, really working on implementing guidelines. On the other side is where you have 100% outcomes-based metrics, such as increased referrals. That's something that you can measure and quantify. Increased testing when warranted. Decrease in medication sold without prescription. And outcomes-based financing, it's not binary. So it's not that you're moving 100% of your funding to one end or the other, but it's sort of shifting. So maybe there are structures where 85% of your funding is still paid up front, but the additional 15% is tied to outcomes-based payments. So that is really, at a very simplistic level, what outcomes-based financing is, and there's lots of flavors of this. I sort of discussed this already, but just to emphasize, there's sort of four main, I think, value propositions of outcomes-based financing. And I'll say that in the health space, we really have not done a good job of leveraging outcomes-based financing as a tool. The sectors that have done a much better job are the energy and climate sectors and education. But health is sort of lacking. So part of this is also just understanding that this tool exists and that we should be leveraging it more. By shifting the focus on measuring outcomes, you naturally shift attention to outcomes. So now all of a sudden, people are more fixated on delivering outcomes than sort of thinking about what their inputs will be. We're also aligning incentives with beneficiary welfare. So if you're designing your outcomes-based instrument, you want to make sure that you're putting enough emphasis on outcomes that are tied to beneficiaries, right? So it's not just about filling out receipts, which you could say is an outcome, but actually making sure that a patient did what you asked them to do. The third one is really important to me, which is providing flexibility to achieve results. If I'm a clinician sitting in Tanzania and you tell me to do something, I can probably do it, right? But if you tell me, I don't care how you do it, but this is the outcome I want to see, that gives me agency and that gives me the innovation potential to say, I know my context and I actually have full latitude to pivot and iterate along the way. And I think that's so important in global health, and we really need to advocate for that. And then the last one is around accountability to beneficiaries. So again, if we pay for results and we deliver on those, even the beneficiaries are able to see and have visibility into that. And I think that's really important, again, when it comes to patient-centric design. It's really making sure that they're part of the process as well. So going back to AMR and sort of what the ideal status is, if you look at the guidelines, you can take WHO guidelines, for example. In an ideal situation, you would have a patient who has an illness, and they would present themselves to a clinician. That clinician in most cases, there may be some clinical diagnosis that they do and they're able to prescribe antibiotics as needed. Or they would refer to a lab who would run a confirmatory test. Then the clinician would write their prescription and the patient would receive antibiotics. Unfortunately, we know that that is rarely happening. And where do we see some of the deviations? The most common one is step 1, where the patient skips all of these steps and actually goes directly to the pharmacy themselves. The second most common one is that the patient actually does go to the clinician, but the clinician's not following guidelines and is writing a prescription for antibiotics. The way that outcomes-based financing would work is that you would actually look at, well, what is the alternative? What's the counterfactual that you want to incent? And in our case, there's sort of 3 points where we want to do that. So the first is what I'm calling A, which is the patient's at the pharmacy, but the pharmacist is somehow incentivized and capacitated to refer the patient back to a clinician. So that's A, and that's going to come up throughout the presentation. Point B is at the clinician level, where how do we incent and capacitate the clinician to follow appropriate guidelines? And then lastly is actually at the patient point of care. How do we incentivize the patient to follow the optimal clinical pathways? So just keep A, B, and C in mind as we go through our approach. So right now, I won't go through all of this, but just to say this is a very long initiative, right? And we're just at the beginning of it. We're just finishing up phase 1, which is what we call the exploratory design phase of, the exploratory phase of the project. We are now just at that top arrow talking about phase 2, which is taking the research results and then translating them into an actual OBF structure. That first diamond that you see is the first stage gate of our project, and that is where we would want a go, no go decision with our ministries of health. And I'll talk about the geography in which we're active. And we have secured funding for what we're going to call phase 3, which is pilot implementation. So we did sort of the research, we'll do the design over the next couple of quarters. And then phase 3, if we're able to get buy-in from the ministry and funding, we would actually pilot this intervention in countries. Many years out from there, if the pilot is successful, we would look to scale this nationally and even globally as context allows. So where we decided to do the research is in 2 urban capitals in Tanzania and Senegal. So that is Dar es Salaam and Dakar. We picked those cities based on many factors, including where our donor Pfizer had interest, where we had as path country offices, and most importantly, where there was government willingness to explore outcomes-based financing. So from the very get-go of the project, we brought the ministry along and made sure that this is something that they were excited about. Our research objectives were really to characterize the drivers of misuse. There was a lot of literature, but nothing speaks better than actually looking and observing yourself, and that's what we wanted to do. And then to be able to use that information to identify OBF instruments, and then finally to assess the feasibility of implementing those OBF instruments. In terms of our scope and our participants, we, for the reasons I mentioned earlier, intentionally chose both public and private hospitals, clinics, and labs. And in those facilities, we interviewed healthcare providers, which included clinicians, laboratory staff, pharmacy staff, and pharmacy owners. And on the right-hand side, you'll see sort of a map of the various facilities that were in scope for us. It's a bit hard to see, but we had roughly 10 facilities in Dakar and roughly the same amount in Dar es Salaam. In terms of project design and scope, there was a lot of debate and conversation around how do we right-size this research phase. We picked urban centers because we knew ultimately we didn't want to pose a barrier on the access front. And we know that if we're sort of thinking about incentivizing patients to go through the formal clinical pathway, that pathway has to exist in the first place, right? Otherwise, we're sending them on a wild goose chase. And so we picked urban centers where we knew the facilities existed and had some capacity to begin with. On the health area side, there was again a lot of debate about, do we pick respiratory illness? Do we pick urinary infections, STIs, childhood infections? And at the end of the day, again, we want this to be very patient-centric, and we don't want to exclude patients, especially at the point of care. And so we expanded our research to be disease agnostic rather than focus on this particular health area. And then for reasons I already mentioned, we intentionally chose both the public and private health sectors. So this is the work of one of our partners, the Healthy Brains Global Initiative, which is an OBF consulting firm. And the way that they look at designing OBF is what they call the results chain, which is looking at sort of how we think about implementation activities in the country. So starting with preparation, activities, outputs, outcomes, and impact. And back to outcomes-based financing, you really want to be able to tie your outcomes or your payments to either outputs or outcomes that are easily measurable. But first, you sort of need to understand your activity and where you think the pinch points are. So going back to that A, B, and C, those were the 3 points of inflection that we focused on. So the pharmacy, clinician, laboratory, and patient. And you'll see this sort of table come up throughout the presentation. This is sort of a detailed look at the postulated root causes of why we're seeing overuse. And at each point, we judge, is OBF the right instrument to counteract these root causes? You'll see these tables come up as well. So just as a reminder, sort of the A, B, and C of where we're thinking about introducing OBF instruments. And now starting at A, which is at the clinician level. So here is sort of a quick summary of the research findings. And again, we have about 140 slides, and I'm just very quickly giving you a synopsis of this. So there's a lot to unpack here. But you'll see on the right-hand column, there's areas where we found that there's evidence that this is happening, and then there's areas where we didn't. So two of the areas where we did see evidence of our postulated root cause happening is around pharmacists willing to sell without prescription and pharmacists being pressured by patients to sell antibiotics. So let me just quickly show you some of the data. So now this is looking at the way that pharmacists are willing to sell antibiotics. And on the left-hand side is the summary of all the data. And on the right-hand side of the graphic is breaking it up by public and private pharmacies. So you'll see that overall, 41% of pharmacists actually felt that there were situations when it's okay to dispense antibiotics without a prescription. And just for reference, that is actually against the WHO guidelines. But 41% thought that there are instances when that is okay. In public pharmacies, that number went down a little bit, so roughly 20%. In private pharmacies, maybe unexpected or expected, that number goes up to 58%. And if you splice this data by country, in Senegal, it's about 67% overall that felt like they had the agency to prescribe antibiotics. And in Tanzania, it was about 27%. So big difference between Senegal and Tanzania. So we'll get back into implications. This is sort of breaking all the rules of presentation in terms of fonts being too small, but bear with me here. So in this graphic, we're showing their responses to the question of how often do you refer patients who come to the pharmacy without a prescription? In Senegal, which is on the left-hand side, the first set is private clinician responses and private pharmacy responses. And on the right-hand side, it's public, and then the same for Tanzania. So I've indicated in the percentages below how often they are reporting a frequency of less than 20%. So 83% of the time in the private sector in Senegal, they are not referring patients to, they are referring patients to go to a clinician when the patient is asking for an antibiotic. That's about 50% in the public sector. And in Tanzania, it's 54% in the private and 89% in the public sector. So really, you're already starting to get a sense of there's really misaligned incentives, and clinicians and pharmacists alike are really not seeing the need, or there's a lack of understanding in terms of what their role is in the patient clinical care pathway. Now moving to sort of the clinician side of things, here some of the evidence that we saw was a bit different again in both Tanzania and Senegal. So some of our postulated root causes that ended up being validated by our data is that the clinician is willing to make a judgment call on disbursement without a test, and that the clinician is being pressured to prescribe the patient an antibiotic. And interestingly enough, we saw a resounding yes for Tanzania, but not in Senegal. So maybe moving quickly to the data, this is Senegal only now. So in responding to the question, are there situations where the guidelines should not be followed? 14% said yes, but the remainder said no, which is relatively good. And on the right-hand side, are there situations where you do not need to have a laboratory test result before prescribing antibiotics? This, while the data here is really interesting, really diving into the nuances of the qualitative response is needed. But just to give you an idea, about half of them referenced emergency situations as being a reason, which again, you see a patient in an emergency situation, you want to be responsive, right? So we can't fault them for that. Respiratory illnesses, this was commonly cited, especially when a parent was bringing their child in. And then other things like cold, flu. I think we all know how commonly we use antibiotics for things like that. Outbreak situations, and then the very generic when evident, which I thought was interesting. And then I think, yeah, this is the Tanzania data. Here, the question is around how often has a patient come to you asking for antibiotics when they do not meet the criteria. And in Tanzania, more than in Senegal, the vast majority, I sort of quantified at 40% of clinicians reported a high enough frequency that this was happening. And I think I have the subsequent slide that says 1/3 of clinicians in Tanzania reported feeling significant pressure from their patients in actually dispersing antibiotics. And that is really validated in the literature as well. So moving to the patient now, this I think is one of the most interesting areas. There were a lot of things that were validated by the research study, but maybe just to start, there was sort of this misconception, maybe not misconception, there was this theory that we had because of what I just mentioned around a lot of literature reporting demand by patients. So we wanted to dig into this a little bit more. So we asked the question of patients, were you hoping to get a specific medication today? And what we learned is that overall in total, about 30% were going to a clinician hoping that they would get some sort of medication in return. Not unreasonable. When we looked further and we further asked the follow-up question of the patients who were seeking some sort of medication, do you have a prescription with you? Actually, the vast majority of them did. This is in Senegal. And we further asked about their knowledge and awareness of antibiotics. Could you name an antibiotic? Do you know what antibiotics do? What the risks are associated with them? In general, the patient level education around antibiotics was relatively low. And so I think this demand for antibiotics is really just a demand to feel better, right? You're not asking for an amoxicillin or anything specific. You're asking for help to get better. And I think that's a very important thing that we need to consider as we look at designing OBF instruments. In Tanzania, it was a little bit of a different story. So in terms of percentages, not drastically different from Senegal, 37, maybe 8 percentage points higher in terms of wanting medication. But a third of folks that were in that category did not have a prescription with them. And this actually, if you remember in a previous slide where we were looking at pharmacies, there was a higher likelihood that a pharmacist would provide antibiotics without prescription. And this sort of aligns a little bit more with that customer demand. So here again, this is why bespoke solutions are really important in these contexts. How am I doing on time? Okay. Maybe this will be my last slide on the data. The other important thing is what is preventing patients from a behavioral perspective in wanting to go see a clinician, right? That's a really important thing for us to understand. In both Senegal and Tanzania, cost and the wait time to see a clinician were the top two. They were swapped. So in Senegal, the waiting time was slightly more of a concern than the cost. And in Tanzania, the cost was slightly more of a concern than wait time. But overarchingly, over 75% of patients we interviewed reported these two concerns. So now when we think about designing an OBF instrument, we have to factor in costs and we have to factor in the wait times if we want this to be patient-centric. So where are we now? So we're sort of wrapping up phase 1. And as I mentioned at the very beginning, we're actually hosting in-country workshops this week. And the whole premise of those workshops is to share these exact findings, slightly more in detail. And instead of us coming up with interventions, actually modeling out with them what they think interventions should look like. So we've given them a bunch of workbooks around, here are sort of the root causes, here are some possible interventions, and we do this sort of at all levels along the value chain. But they'll go through this exercise where they will map all the interventions that they've brainstormed together as a group, and then map this on a sort of ease and impact 2x2 matrix. The project team will then work with our consultants to take those that we think are in that top right quadrant as our starting point for things that we can design around. And so that would sort of help us move from phase 2, the design phase, into phase 3, which would be the pilot implementation. And so the next step is really looking at sort of doing these design sprints. I know that that's terminology that you all are very familiar with in terms of taking their feedback, rapidly designing, presenting back, and really allowing this to be owned by the ministries of health. And then hopefully in the June timeframe, we would sort of come close to a final design. And that's where we would seek final buy-off from the ministries of health. And then we would look to raise funding to actually implement these in one or both geographies, Senegal or Tanzania. So I think that's pretty much, yes, my presentation, and I'm happy to take any questions. Thank you so much.
Thank you so much, Neha. I think what I really valued in how you laid this out is you made it so clear all the different stages and the fact that you're working with community partners and you're doing in-depth design instead of presuming we understand what impact should be measured and what are the outcomes that are really important. So I just really value that humility and collaborative approach to the work. Thank you so much for sharing it. And I think for our biodesign fellows, we've just recently been teaching impact assessments and also thinking about how to think long-term about outcomes. So I hope it added a lot more context to some of the work we've been doing. And we are going to move to questions now for our online and in-person audience. For the online audience, if you have a question, please just type it in the chat and we have someone moderating the online session. And for the in-person audience, can I just ask, if you have a question, please just say your name and where you're from so we also get to know some of the new faces who are not part of the Biodesign Fellowship group, as we are really happy to see lots of new faces in the room. So would anyone like to kick us off with a question? Start.
Hi, I'm Anastasia from Greece. I wanted to ask about maybe the next stage, the implementation of the OBF, the actual logistical process of you talking with the founders. Are they gonna eventually fund the interventions that have been developed through this outcome-based approach? Are they gonna give you a part of the funding and hold a part of it based on the outcome? What happens if you don't deliver that outcome, like the logistics from the funding side, if you can share?
Yeah, that's a great question, and one I don't have a full answer for. But what we've been really discussing is that in the implementation phase, right, with any pilot implementation, you want to make sure you're setting yourself up for success. So you might not want to throw everything at it in its first instance. You might want to test out a couple of variables before you start locking things down. So what we've discussed is maybe having like the backbone of an OBF instrument, but not necessarily having in the pilot implementation, the payment be based on outcomes in the very beginning stages. But for sustainability purposes, there's a lot of debate around to what extent the ministries of health and the governments themselves should be paying for outcomes versus having that be donor funded. And so there is sort of, I don't know if you're familiar with the Gavi approach, which is really looking at sort of graduating into various funding tiers. So you start with this understanding that this is a net new thing and that there's going to be some startup costs associated with it. So maybe the donor comes in at 100% for the first couple of years, with the intention that eventually it's a stepwise function. You go to 20% government ownership, 40% government ownership. And by year 5 or 6, it's actually the government that's fully owning and paying for the instrument themselves. So we're sort of discussing a lot of that right now. I think because there's so much movement in the funding ecosystem right now, that does complicate discussions quite a bit. And so we're looking to figure out, what variables are important for us to test and what can we lock down, particularly on the funding side.
May I just add a point of clarity for those of you who aren't familiar with Gavi? It was mentioned it's the Global Vaccine Alliance, and it's a private public partnership between governments and various pharmaceutical firms to make sure that every child gets vaccinated, regardless of where you live, and a really interesting business model. Just wanted to name that acronym. Erica, you had a question.
Yes, hi, I'm Erica. I'm one of the policy fellows here in Biodesign. And I also used to work with our Ministry of Health back in the Philippines. So thank you for showing the beautiful logic model or results chain. And I think that's my main question, because I do understand when you have things that are outcome-based, M&E is a huge part of it. And I'm wondering, what are the strategies to implement or to work with the Ministry of Health and the Ministry of Health towards the other people who will be collecting these data moving forward, because that is, from what I've noticed, the biggest challenge with something like this. So if you could share strategies that you're looking into or you already know of, that would be great.
That's a great question. And it's funny because that was the first question our OBF consultant asked us, is what systems are in place where we can actually measure outcomes. So part of our research, I didn't talk about this in depth, is actually doing a gaps assessment of the facilities that we interviewed. So there are 10 facilities in each country to understand actually their back-end data capture mechanisms. So what are they reporting? What are they reporting? And in the pilot implementation, we will down select facilities that already have that infrastructure in place. Of course, there may be small investments that we need to make in facilities to be able to bring them up to par. But again, back to your question around how much can we tackle all at once? I think once we can create sort of these positive deviants around where the capacity exists and the value of that capacity, then I think the government can make those similar investments across the various pockets. But we would probably want to start, again, just to set ourselves up for success, where capacity to measure and evaluate are already pretty well established.
Hi, thank you for your talk. I'm Pinu and I'm an undergrad in CS and Econ. And I was curious that, like, with these evaluation metrics, like, it's very important for lots of nonprofit organizations and funders and also just other investors. But what do you think should be the people that are responsible for evaluating the metrics when it comes to like outcomes-based financing. Like if you have an organization, how should the organization be set up to do this? Is it like self-reported data? Are they supposed to have their own like evaluation team, or is it the government that should be responsible for this?
Yeah, that's a really great question. And again, channeling our OBF experts, independently verified outcomes is always the gold standard. So even in our future pilot, anyone involved in the design process is really sort of, in a way, conflicted as the measurement entity as well. And so it's really important to bring somebody independent who hasn't been involved in the design phase of the project or is not getting funding for its success, to be able to come in and be able to measure outcomes, because those become the audited measurements that go out to broader swaths of folks and stakeholders to be able to say that, you know, these outcomes were truly met. And so I think managing conflicts of interest is really important on that front. But I think maybe embedded in your question is a second question around data ownership as well, right? So a lot of this information, it's coming out of the public health sector, the private health sector. There's patient level data there. And I think that in terms of who should be owners of that data, I think that really should belong to where the data was generated. So public health sector and ministries of health, the people themselves, and in private networks, those private networks should have that information. And so I have seen examples where, you know, all of this fancy infrastructure is set up and that data is not being fed back into those that are generating that data. And that's also a problem. So I would say that those are two very important things that are related.
I'm Austin, one of the Innovation Biodesign Fellows. How do you figure out the benchmarking process? Because I think in the States, one of the challenges, especially for like pay for performance with Medicare, is do you set like a national or regional average and then take the difference between the regional average and the local site? Or do you take where the local site is at and then calculate like a % improvement customized to each local site?
Yeah, that's a really good question. And I think the answer to that will depend on the scale at which you're thinking about implementation. In the pilot implementation, we would start very localized and actually look at facility by facility level benchmarking, just because we know, and we've even seen in the data that there's a lot of variation in the way the 10 facilities responded to questions. And saw the map. It's amazing the diversity in terms of the demographics of patients, even in urban centers. And so you'll have certain areas that are meeting the demands of a very different clientele than in other areas. And so I think benchmarking at the facility level in its first instance is really important. As you reach scale, I think you can sort of broaden that, you know, the concentric circle in which you're benchmarking. So you can start looking at urban areas or semi-urban areas and create more of a benchmark. Benchmarking also sort of assumes you have really good data already. And so part of why our pilot implementation is going to take a little bit longer is we recognize we're going to have to do a lot of the benchmarking ourselves. We can't just rely on those benchmarks existing. So yeah, great question.
Thanks. I'm George, the GFIT Fellowship. Now, I was just curious, just seeing you've selected Tanzania and Senegal. These are really countries with really very diverse backgrounds in terms of culture. How then do you intend to model this so that, and it is interesting, even up to now, the data is not showing so much disparities. You look at Tanzania, basically English speaking country, Senegal, French speaking country, yet this is not emerging from the data. How do you account for this?
Yeah, it's a good question. And to be honest, we also wanted to include India in this original study, right? Because India just throws everything off in so many ways, right? Population-wise, diversity-wise. And I think what I'm learning, and again, going back to the humility, is that when we talk about scale, it's really one of these sort of made up things where we say we learn something from one context and we can apply it to another context. And our human subjects research group always keeps us very honest when we talk about scale, because they want to make sure that we are not overgeneralizing what we're learning. Even in the context of Tanzania and Senegal, our work here is not necessarily going to scale nationally, because how rural healthcare is delivered will be very different. So I don't know if I have a perfect answer for you, except to say that, you know, we wanted to start with two country contexts where we already had a really strong relationship with the ministries. We understood that the willingness was there to test new ideas. And I think ultimately, if you look about sort of determinants of success, I think that is a huge one. Everything else from there can sort of flow down and work itself out, including managing sort of differences. One of the things that we're sort of thinking about now is how different are the pilots going to be in Dakar and Dar es Salaam? And do we want to be strategic about that? Like, do we actually want to introduce differences so that at least we can learn a little bit more on where our approach has diverged? But at the end of the day, it's two implementations. And so I think the jury's still out in front of what will be generalizable and what will not.
Before we move to our question at the back, and to so you had your hand, I do want to encourage those of you online to also ask questions. The reason we make this online is because we can't have a talk about health equity and not think about equitable access, and we value the fact that so many of you joining online and joining from around the world. So if you do have questions, please put in the chat. It's just not just for those in London. Until we get a question though, we will go to Ant up the back.
Hi, thank you very much. That's very interesting. I'm a family physician from Canada, and I'm one of the global fellows here. I've been involved in many antimicrobial stewardship programs through Choosing Wisely and other organizations. Perhaps you've heard of them. But I was wondering, are you ready to maybe only get a 10 to 15% difference in the end? Because this is the way I see it, as a big quality improvement project. And when systematic reviews look at the outcomes, you only affect the outcome maybe by 10 to 15%, no matter what you do, even if you have these different incentives, in your case, a financial based outcomes incentive strategy. So I wondered if you consider that, because that's what the evidence says. No matter what we do, we only really probably change with this complex behavioral problem. Maybe only 10 to 15%, and that I suspect wouldn't be enough to really make a difference. And you'll find out in like 5 years' time that a difference of 15%. This has been my experience with many similar programs, albeit in different countries or in Canada especially. So I just wondered if you thought about other, and I guess you're in that phase where you're looking for things still. You don't know what exactly, but like, the heavy-handed levers are often like, if you want to test to stopping audit, you just remove it from the requisition, and then you can't order it anymore. It sounds sometimes those things. I wonder what you'll find, but it sounds very heavy-handed. But we found that trying to get clinician behavior to change is almost impossible.
Yeah, I think it's a really good question. I mean, I would say that there's the way we're approaching it is really in the context of all the other interventions, right? We're not trying to replace the other interventions. I kind of blew through the last slides, but education and advocacy is a big component. The clinical stewardship programs are a big component. This is really layering on top of those as a mechanism to do exactly what you just said, which is influence behavior. And I think it's the behavioral elements that really haven't been tackled by existing efforts. And so I don't know if 10 to 20% is what we'll get. I don't know if that will be satisfactory, but I think the point is, and a big piece of this is, how much will this program cost, right? And is it cost effective? It could potentially be cost savings, right? And so all of those things are parameters that we would have to test in the pilot. And I would say, depending on the cost effectiveness of it, 15% on top of what is already happening could be great. 20% higher than that, really, it really just depends on what we're expecting the cost to be and how effective the other are. There was a really great study done on education and how long sort of the residual effects of education once you stop the educational program. And on average, it was about 18 months that you would see effects, and then it sort of goes away. And so you have to invest again. I think one of the things that makes me really optimistic about something like this is the financial incentive aspects, which I think drives so many people on a daily basis, right? And as long as that incentive is there, you're going to see some of that behavior change. So it's a novel approach. I do think that there's a lot of risks around it, but I'm hoping that it will really augment in a way that would be.
You think you'll get to paying them?
Sorry, I'm going to stop you there because we have an online question and I would love for us to finish on time to honor everyone's time, but feel free to engage afterwards. Antia, do you want to share our question?
This should be a short one, I think. Asia Echevarri Queen is asking, who is your consultancy or partner in the OMB? And I assume they mean the Office of Management and Budget.
I don't know. Yeah.
You're not working with them?
No.
Okay, yeah, that's a good answer too.
Is that in reference to the ministries, the OMB and the ministries?
I would assume so. The question came in about 15 minutes ago. Yeah.
Okay. Yeah, I don't know off the top of my head. The workshops that we're hosting do have multi-sectoral partners in them. And so there may be somebody representing the OMB in those workshops, but typically speaking, we've engaged with the technical working groups for AMR. There are financial folks that sit in there, but I wouldn't be able to tell you who they are.
I think that's a good answer. Thank you.
Wonderful. We're going to have to pause questions there because we have 2 minutes before the end. But for those of you who still have questions, feel free to hang around afterwards and please have a chat with Neha. But we do have something more for you to say thank you for a really wonderful talk. We hugely appreciate it. And we just really value the fact that you came here and showed what you're learning and what you're doing. And it's still very much progress being built. And we so value being taken along on the journey. And I think we've all drawn inspiration from the fact that here at Biodesign, we're starting to tackle really hard health equity problems when it comes to innovation that traditional funding mechanisms don't work for. So how do we learn from new and emerging practices like yourselves? So thank you so much, Neha. You've really showed us a lot. Can we give her a round of applause? And just as we wrap up, I am just going to run through what's happening in the next few sessions. Just get out of your way to positions. So we do have our next speaker on the 11th of March, who is Jane Chen. She's the founder of the Brace Baby Warmer that many of you may know of, a very famous global health innovation. And Krista Donaldson is going to be having a frank discussion with her on lessons on leadership and global health innovation, what she's learned over the years. For anyone who would like to join, you're most welcome. Again, it will be open online to everyone via Zoom. And then on the 8th of April, we're going to be hearing from Sarah Olson of the SVT group, talking about impact assessments and health innovation. It's a really important theme about monitoring and evaluation and how do you know you're making a difference, right? And then we have some events that our partners would like us to organize. So on the 6th of March, from 12 to 1 p.m. in the DK room in the Haas Center, there's an event with the Global Health Graduate Network with Josh Nesbitt, who you can find more about them on their website, and it is open to any Stanford affiliates. And then on the 6th of March, again from 5 to 6 p.m., so both of these events on the 6th of March, Professor Philip Clarkson, who's the Vice Chancellor of the University of Global Health Equity in Rwanda, is coming to speak. And also an event through the Center of Innovation in Global Health. Again, please go on their website if you'd like to find out more. And then, as usual, we don't have our as usual slide, but if you would like to learn more about Bay Area Global Health Alliance, please go on their website. It's the next slide. Oh, in the beginning. Okay. Well, I'm just going to talk you through it. If you'd like to learn more about the Bay Area Global Health Alliance, because as you've seen today, They're playing a fascinating and really integral role in our ecosystem when it comes to catalyzing, connecting, advancing. At Stanford, all of you here are members as a result of our institutional affiliation. If any of you online are interested in learning more, please do get involved. And Sarah Anderson, thank you so much for being here today and for continuing to support our series. We are going to invite you all to do a brief survey quickly. If you want to whip out your phone, it should be 1 to 2 minutes. And then we're going to close the session. For those of you online, please feel free to also do the survey. So we've been hosting these talks for about a year and a half now and have learned a lot, have covered a lot of themes. And we actually want to give you, the audience, a moment to engage and tell us, what are you enjoying? What speakers do you have in mind for future? Where could we grow and improve? As our community goes, we want to be responsive to the needs of everyone, including those of you online. So I'm going to give you a minute before wrapping up the session to do that. Great, I see some people are finished. For those of you still busy, no need to rush. But I'm going to wrap up the session and just say a big thank you to our speaker Neha today for sharing, for Sarah for being present, for all our partners for contributing, and Antje, Danny and Deja for being the amazing team I get to work with to host these events. Thank you for those who are joining online. The Health Equity Center program is growing from the Biodesign Center. So if you or your organization are looking to become more involved in health equity and innovation efforts, please do get in touch with me. My email is on the program brochure for today. And we hope that if you've missed a series, you can find it on the YouTube recording channel where all prior talks are here, thanks to Danny. And we hope that it'll serve as a resource for insights on health equity and innovation. Now I'm going to bring the online session to a close. Thank you so much for joining.